Diseases of the posterior pituitary really involve two diseases, diabetes insipidus and the syndrome of inappropriate antidiuretic hormone secretion. And we're going to talk about first about diabetes insipidus. So diabetes insipidus is a disease where we have either deficiency in antidiuretic hormone or unresponsiveness to antidiuretic hormone. Antidiuretic hormone deficiency occurs with central diabetes insipidus, where antidiuretic hormone unresponsiveness, so you have enough of antidiuretic hormone but it's unresponsive. Where does it work? In the kidney, so the receptors are unresponsive. That is referred to as nephrogenic diabetes insipidus. So remember, antidiuretic hormone is the main water-retaining hormone in the body. We need antidiuretic hormone to hold on to free water when we get dehydrated. And so when you're missing antidiuretic hormone or when this is unresponsive, we develop polyuria, polydipsia, just like any other form of diabetes, but now we don't have an elevated glucose, what we have in diabetes mellitus, and that's why this is referred to as diabetes insipidus, insipid urine, meaning free of glucose. So these patients usually present with polyuria, polydipsia. If these patients are without water, if something happens to them, they get admitted to the hospital where people don't give them enough water because they're pre-surgery, or something happens to them, they develop a febrile syndrome and they lose access to water. They develop severe dehydration and hypernatremia. Because these patients don't have antidiuretic hormone, they have excessive and dilute urine, and when you measure their urine osmolality, it's low urine osmolality, meaning low inability to concentrate the urine. So at the same time, with the low urine osmolality, you have elevated serum osmolality and hypernatremia. So look at this. The patient develops diabetes insipidus, they lose free water, so their serum gets dehydrated, their serum osmolality increases because they're losing free water, their serum sodium goes up, that's relative to the serum osmolality, so both of those increase, serum and sodium, serum osmolality and sodium serum are elevated, but at the same time you find a paradoxical response. You find a low urine osmolality. Basically, this patient is getting rid of dilute urine. So think about the normal patient. If a normal patient develops dehydration, they don't lose free water, they concentrate their urine to hold on to all the free water they could hold on to. That's the typical response. But this patient has an increased serum osmolality and at the same time a low urine osmolality. How do we diagnose these patients? Basically, we diagnose them based on these two things, finding a lower urine osmolality at the same time when we find an increased serum osmolality. And the test to do is the water deprivation test. The test to diagnose diabetes insipidus is called a water deprivation test. Now, you have to be careful. A patient with diabetes insipidus gets dehydrated really quick. So when you do these water deprivation tests, they ask you on the boards, what do you have to be concerned about? And you have to be concerned about if the patient really has diabetes insipidus and you let them do this water deprivation test and you put them in a room and nobody attends to this patient for hours, they could come back later and they could be severely dehydrated. So they want you to know that once you consider diabetes insipidus, if you're going to do the water deprivation test, this patient has to be monitored closely and they have to have some kind of IV line, so in case they get dehydrated you could give them quickly normal saline and fluids and resuscitate them really quickly. So the water deprivation test, this is what it should look like. You're taking a patient and you're depriving them of water, and what happens is you measure urine osmolality. Here's urine osmolality to the left, right here. Here's urine osmolality, and you could see urine osmolality here this is dilute urine, so the urine osmolality is low, and this is concentrated urine. It's going up here as we go to 1400. On the other side here is you got plasma osmolality or serum osmolality, and we said that's usually relative to sodium. If the glucose and the BUN is normal, the plasma osmolality usually is about sodium. And you could see that this goes from 276 to 300 or a little bit above that. Really, this is a very, very tightly a tight system here. You don't fluctuate your plasma osmolality left and right. You know, you control that very, very closely. Now, if we take a patient and we water deprive them, you'll notice that in the beginning, take a normal patient here, you look at the patient in the beginning, their serum osmolality is low right here, and at the same time, look at their urine osmolality, that's low too, right? So you're not dehydrated, so you're putting out dilute urine. And now as you water deprive them, their plasma osmolality starts to increase here. You see that, and at some point right here, right at some point around here when the patient's plasma osmolality is increasing, you secrete antidiuretic hormone, and look what happens here. It increases a little bit more, but it tapers off. It tapers off. You don't continue to increase your plasma osmolality because you don't get more dehydrated because you're holding on to free water. And what happens now to your urine osmolality? Look at here. Your urine osmolality now is very high. So you're concentrating your urine here. So what happens in a normal scenario, as you deprive somebody of water, you're dehydrating them, their plasma osmolality increases. As that increases, you kick in your antidiuretic hormone. Your antidiuretic hormone holds on to free water, and what does that do? You taper off the worsening of the plasma osmolality so you don't continue to get worse and worse and worse. And what happens is you notice that your urine osmolality all of a sudden goes up because you're concentrating all your urine, you're concentrating your free water, you're holding on to free water. Why are you holding on to free water? To try to minimize the dehydration in this patient, and you get a curve like this. You get a curve like this, just like exactly like this. Now, take a patient now with diabetes insipidus. Look at this now here, down here. This patient gets dehydrated and dehydrated and dehydrated. Now their plasma osmolality is 292, and look at their urine osmolality. Very low here. So the inability to concentrate urine, and if you continue to do this, you continue to deprive them of water, and you're measuring plasma osmolality and urine osmolality, you continue to get the same thing. You get an increase in plasma osmolality, right, from one point to the other, and at the same time, the patient has dilute urine. That only happens in diabetes insipidus. So an increase in serum osmolality, while at the same time inability to concentrate urine, low urine osmolality, that is diagnostic of diabetes insipidus. Now the question is, right at this point here on this graph, what does the patient have? Does he or she have diabetes insipidus central type, or do they have nephrogenic diabetes insipidus? The answer is you don't know. You have to do one more test here to show what this patient has. Is it central or nephrogenic? And at this point, you give this patient, right at this point here, you give them antidiuretic hormone. You give them antidiuretic hormone, and what happens is, if the patient starts to concentrate their urine, just like this patient does here, look at this, they start to all of a sudden concentrate their urine, this patient has central diabetes insipidus. They were missing vasopressin, they were missing antidiuretic hormone, you gave them antidiuretic hormone, now all of a sudden they concentrate their urine. That's what you see right here, concentration of their urine. Right here, after, at this point, what did you give them? Antidiuretic hormone, right at that point. Now, if the patient continues to have the same flat line, they're going to get worse. Not because you gave them antidiuretic hormone, because basically, they can't concentrate their urine. If you continue to have a flat line here, despite antidiuretic hormone, then what does this patient have right here? They continue to have a flat line. The answer is nephrogenic diabetes insipidus. Remember, these people have antidiuretic hormone already on board. It just doesn't work in the kidney because there's something wrong with the receptors. That's the bottom line. So they may ask us here, what causes central diabetes insipidus? And the answer is anything that is space occupying in the brain, anything in the brain that would disrupt the hypothalamic pituitary axis, because remember, antidiuretic hormone is made in the hypothalamus and then transferred and stored in the posterior pituitary. Anything that would disrupt that would cause central diabetes insipidus. Like what? Any space occupying lesion, any trauma to the brain, any granulomas to the brain, like tuberculosis, like sarcoidosis, like an abscess in the brain. So anything space occupying in the brain would do this, central diabetes insipidus. What causes nephrogenic diabetes insipidus is very interesting. Basically, it's medication. Lithium is number one. Demiclocycline, a form of tetracycline, is number two. We use this sometimes for acne, and people have been taking it for a long time, develop diabetes insipidus. And then some rarer forms of diabetes insipidus, like hypercalcemia, extreme hypercalcemia, could cause diabetes insipidus. This is why patients with hypercalcemia develop severe dehydration, and this is why one of the treatments in hypercalcemia is to give them a lot of fluids. Give them a lot of fluids because they have diabetes insipidus and they're very dehydrated. Patients with sickle cell disease sometimes develop nephrogenic diabetes insipidus, but as I told you, I want you to remember the two most common forms, which is drug-induced diabetes insipidus, and that's from lithium and demiclocycline. Now, they may also ask you to show this water restriction test as a form of urine volume and plot it against serum osmolality. And if you remember the prior one, then you'll remember this one. Here we got urine volume. Urine volume is going up, right, from down to here. We're going up on urine volume, and the serum osmolality is increasing here. So in the beginning, when you deprive the patient, of fluids, they have high urine volume, right? And then they start to get dehydrated here. The serum osmolality increases, and their urine volume now, because antidiuretic hormone has kicked in here, somewhere around here, somewhere in this here, now their urine volume, boom, right, goes really down. Really goes down, because now you don't, if you get dehydrated, you don't put out a lot of urine. You concentrate all your urine volume. You don't put out, if you're dehydrated, you don't, urinate a lot. You hold on to your urine, you hold on to your free water, basically to dilute down the dehydration. A patient with diabetes insipidus, while they get dehydrated, look at this, their serum osmolality is increasing. Their urine volume at the same time is very high here. So urine osmolality increasing, urine volume at the same time very high, and this patient, despite serum osmolality increasing here and their urine volume being very high, what is the diagnosis? The only diagnosis this could be is diabetes insipidus. What type? We don't know. We have to give antidiuretic hormone here, and if the urine volume starts to go down like here, this patient has central diabetes insipidus. If this patient continues to get dehydrated here, despite antidiuretic hormone, this patient has nephrogenic diabetes insipidus. So this is called the water deprivation test. They may ask us a question, well, if a patient has polyuria polydipsia, they don't have diabetes insipidus because they have a normal curve like this. They don't have diabetes mellitus because you've excluded that before you did this water deprivation test anyway. So what do these patients have that have polyuria polydipsia and have normal water deprivation tests, like here, like this kind of curve? And the answer is they have this thing called psychogenic polydipsia, where they drink a lot of water. So they drink a lot of water, they pee out a lot of water, and that's why they present to you with polyuria polydipsia. Causes we've talked a little bit about, but I want to give you the full thing here. So the causes we said of central diabetes insipidus are anything in the brain, anything space occupying in the brain, neoplastic or infiltrative causes. Sarcoid would do it, and tuberculosis would do it. After surgery, especially neoplastic surgery to the brain, you may have it. Radiotherapy to the brain will do it, and after trauma will do it. So this is anything to the brain, anything that disrupts the hypothalamic pituitary axis could do this. And then I told you nephrogenic diabetes insipidus. I want you to remember especially lithium and demiclocycline. I also told you you could see it in extremes of hypercalcemia and sickle cell disease, but I want you to remember with nephrogenic diabetes insipidus, lithium and demiclocycline. I also want you to remember here that nephrogenic diabetes insipidus has elevated antidiuretic hormone levels, right? Can you have a diabetes insipidus with elevated antidiuretic hormone levels? And the answer is yes, nephrogenic diabetes insipidus, because these people have antidiuretic hormone from the posterior pituitary. That's not the problem. The receptors, though, don't work, so their antidiuretic hormone levels are usually elevated. So I want you to remember that. A little bit about the treatment. Now, the central diabetes insipidus, remember, they're missing antidiuretic hormone. So if they're missing antidiuretic hormone, what do we give them back? We give them back a form of antidiuretic hormone. I said a form of antidiuretic hormone. We don't like to give back vasopressin or antidiuretic hormone, the typical one, because we like to use that in the water deprivation test. But remember that not only has antidiuretic hormone properties, but it also has vasopressor effects, right? Vasoconstrictive effects. So your blood pressure goes up, your heart rate goes up. So you don't want to be using that kind of drug every day. What you want to use is a form of antidiuretic hormone. It's called desmopressin. Desmopressin has one amino acid difference than antidiuretic hormone. And with this one amino acid difference, you only get the antidiuretic effects when you use desmopressin versus antidiuretic hormone vasopressin, where you get the vasopressin effects and the antidiuretic hormone effects. So desmopressin is the drug of choice. It's a great drug, and it's used intranasally. I want you to remember that it's used intranasally. These patients use it a couple times a day. So they squirt themselves in their nose a couple times a day with desmopressin, 3 times a day, 4 times a day, and it works fabulous. Now, desmopressin is used in other diseases also. It's used in hematologic diseases. It's used in von Willebrand's disease and mild hemophilia A, because it also secretes other stuff. It secretes von Willebrand factor VIII and procoagulant factor VIII. So remember that when you're thinking about desmopressin. Now, nephrogenic diabetes insipidus, on the other hand, we can't use antidiuretic hormone. Remember, these patients have antidiuretic hormone, it just doesn't work. So what do we use? As long as these patients have access to water, they have access to water, you have to stop the medication that's causing nephrogenic diabetes insipidus. You have to give them access to water. These patients usually, they know how much they have to take in, right? They kind of, they kind of regulate themselves. And then the drug of choice is either a diuretics, a mild diuretic like hydrochlorothiazide or amiloride, or a non-steroidal anti-inflammatory drug. One of these two drugs will do. Now, they like on the boards to ask about the diuretics. How do we, what is the treatment of choice for nephrogenic diabetes insipidus? They want you to know about the diuretics, because it sounds a little bit like of a paradox that these patients with diabetes insipidus, they urinate, tons of volume of urine every day, and you give them a diuretic to urinate even more. But what you're really doing with a diuretic is you're holding on to more free water and getting rid of more salt. So as long as the patient has access to water, this gives a better balance of fluids and electrolytes. So the treatment of nephrogenic diabetes insipidus is a mild diuretic, non-steroidal, access to water. They need to drink as much water as they have to, and you stop the medication, whether it's lithium or demiclocycline. Please be careful. They may ask us about a case of diabetes insipidus that doesn't manifest before. So for example, these patients have polyuria, polydipsia, but they haven't noticed that. So they don't come complaining to you. They sometimes manifest because they lose access to water. So they may tell us about a young person who has been taking lithium, and in that long history there, they tell us, they have a lot of other things going on, and they tell us they went in for some kind of surgical procedure, and what happens, before and after the surgical procedure? Well, we keep them nothing by mouth, right? We deprive them of water, we don't give them any access to water, and these patients, if they have diabetes insipidus, they manifest it because now what happens is you deprive them of water, and they develop severe dehydration and hypernatremia. The way to diagnose that on the spot is that you will notice that this patient has severe dehydration, they have hypernatremia, and at the same time, when you check their urine osmolality and their urine osmolality and their urine specific gravity is very low, meaning that they're putting out dilute urine. So please look into that when somebody develops acute hypernatremia, acute dehydration. Think about diabetes insipidus that was unmasked because the patient lost access to water. The other side of the coin is the syndrome of inappropriate antidiuretic hormone secretion. This is the exact opposite of what diabetes insipidus is. And now in these patients with SIADH, inappropriate antidiuretic hormone secretion, you have free water retention. So remember, you're inappropriately secreting antidiuretic hormone. So what do? Because you have too much antidiuretic hormone, you hold on to free water, and what this does is it expands your extracellular volume, and then you develop hyponatremia, and these patients come in usually with symptoms of hyponatremia. Symptoms of hyponatremia are the same symptoms as hypernatremia. They're usually central nervous system manifestations like seizures, like confusion, like altered mental status, and so forth. Despite all this, it is very interesting that the most notable thing about this syndrome, despite holding on to all this free water and expanding your extracellular volume, these patients do not develop edema. I mean clinical edema, pedal edema, and they don't develop hypertension. There seems to be some kind of mechanism, escape mechanism, where these patients hold on free water enough to dilute down the sodium and to expand their volume, but after a certain point, they get rid of this water, not all of it, some of it, in order not to develop edema. So please remember this. SIADH, we cannot have edema, clinical edema. If we do, it's not SIADH. We only think about, we're going to talk about it later, we only think about SIADH in euvolemic hyponatremia. At the same time, these patients, they develop hyponatremia, right? Extracellular expansion, so the hyponatremia is evident. At the same time, you notice that the fluid, the urine fluid is very concentrated. So serum hyponatremia, and at the same time concentrated urine. So which is a paradox. In a normal patient, you shouldn't see that. If a patient develops hyponatremia, what does the patient usually do? Get rid of free water to stabilize, to bring the sodium back to normal. Because the urine is so concentrated, because the urine in SIADH, all the free water is taken back into the body, is reabsorbed, these patients show evidence of elevated sodium in the urine. Not so much because they're getting rid of so much sodium, but basically because they're holding on to all free water. So serum hyponatremia, concentrated urine, and natriuresis at the same time, a urine sodium that's elevated with no edema, that's the scenario, the classic scenario of SIADH. As I said before, most of these patients, when they present with symptoms, when it's not found incidentally, they present with symptoms of hyponatremia. And what is that? Some form of CNS manifestations, irritability, confusion, seizures, altered mental status. Now, I said the same symptoms occur with hypernatremia. So hypernatremia and hyponatremia present exactly the same way. There's no difference. Now, I said the clinical PER is consider SIADH in all cases of euvolemic hyponatremia, not patients with edema, not hypovolemia where the patient is hypotensive. You can't consider SIADH. These patients have something else. They have other causes of hyponatremia. SIADH, we only consider it when the patient is euvolemic, clinically euvolemic. So please remember that they don't develop edema, these patients. So how do we confirm the diagnosis? We already talked about this. Hyponatremia is evident this is in the plasma, in the serum. Plasma osmolality, because the sodium is low, is usually low. And then at the same time we find small amounts of concentrated urine. And because the urine is very concentrated, the urine sodium is elevated because the urine is so concentrated, and this is called inappropriate natriuresis. It's not really natriuresis so much as it is that you're concentrating all the free water. These patients also have some other stuff. Low BUN. It seems that you get rid of a lot of BUN and a lot of uric acid, so there's low BUN in these patients, and uric acid is decreased also at the same time. And then in order to be able to diagnose SIADH, you have to exclude some other diseases that look sometimes much like it and cause hyponatremia. And that is thyroid disease, you have to exclude hypothyroidism, and adrenal dysfunction. So they tell you, what else do you check before you make the diagnosis of SIADH? Check a TSH, check cortisotropin, cortisol levels, to exclude adrenal dysfunction, to make sure this is not what it really is and it's really SIADH. Once you've made the diagnosis, then you have to think about a little bit about the etiology, because the workup would be to look for one of these causes, even though a lot of times it's idiopathic, we have to exclude some of the other causes. So etiology is one group of diseases, are the pulmonary disorders, right? Anything chronic in the lung could cause SIADH. For example, cancer in the lung, especially small cell cancer, oat cell cancer, is typical to present with SIADH as a manifestation of paraneoplastic syndrome. Then you have other chronic lung diseases like tuberculosis, sarcoidosis, lung abscesses, even COPD could do this. So any chronic lung disease could present as SIADH. And then any central nervous system disorder. Now, the same central nervous system disorders that cause diabetes insipidus, the same stuff, any space-occupying lesion in the brain, any abscess in the brain, any TB in the brain, could cause SIADH. So the same diseases that could cause diabetes insipidus, central diabetes insipidus, could cause central SIADH. So please remember that. If you remember diabetes insipidus central, the causes, then it's very easy for you to remember the central nervous system disorders that cause SIADH. And then the third category is the drugs: chloropropamide, vincristine, vinblastine, cyclophosphamide, and I want you to remember especially the SSRIs, serotonin reuptake inhibitors, especially sertraline and some of the alike drugs. A lot of people are taking these medications now for various reasons, for anxiety or depression, and they present with hyponatremia as a manifestation of SIADH. So please remember that. That's the drug I want you to remember. How do we manage SIADH? Well, number one is you treat the underlying causes, but as a treatment right up front, because if you don't treat it symptomatically, then your sodium continues to drop, and then the patient becomes all in more symptomatic. So the number one thing is to do fluid restriction. Fluid restriction is the first and foremost thing, because sometimes we could reverse this quickly just by fluid restriction, and we restrict the patient to about 800 to 1,000 mLs per day. Some people say even 1,500 will do, because it's kind of hard for the patient only to drink 800 mLs per day of all fluids. This is all fluids, not only water. So that's the number one thing. And then we give the patient a chance, a couple weeks, to, as long as they're not having any worse manifestations, to be able to stabilize the sodium. And if this doesn't work, the fluid restriction doesn't work, then we try treating the patient with drugs, the same drugs that cause diabetes insipidus. Now we use them to cause a diabetes insipidus in patients with SIADH. So in order to treat SIADH, and the first drug of choice, if fluid restriction doesn't work, is demiclocycline. This is the most benign one, and that's the first drug of choice if fluid restriction doesn't work. We use demiclocycline to reverse SIADH. Now, lithium is also another option, but I put a question mark after lithium here, because lithium is very toxic, and you want to use it only when you have to. So demiclocycline is by far a better choice here. Some people have asked me, what happens if a patient presents with SIADH and severe symptoms like convulsions, like seizures? Then the answer to that is we treat them with hypertonic saline. It's one of the few times where we give a patient hypertonic saline. For part 2, you will have no other scenario likely that you will have to use hypertonic saline. I doubt they're going to ask us about SIADH and hypertonic saline, but it's good to remember this is the only scenario if a patient is very symptomatic, has seizures, confusion, very symptomatic. We use hypertonic saline, right, over 3-4 hours. Some people, along with the hypertonic saline, would give a touch of furosemide. But basically, this is the only time where hypertonic saline is indicated in the treatment of a patient. So again, what do we do first? We fluid restrict along as treat the underlying causes. And then if that doesn't work, we go over and we use demiclocycline, and that's how we treat SIADH. And this is the end of the diseases of the posterior pituitary.